is Megan Gallagher. I work for Save the Children, and I'm representing the co-chairs of the Humanitarian and Crisis Subcommittee of ICFP. My other co-chairs are Dr. Grace Cadindo, Julie Taft, and Sarah Casey. We are so happy that you can join us today for this exciting panel. Before kicking off, I wanted to talk through a few housekeeping items. First, translation. Translation will be important for this session as a presentation will be delivered in French. To that end, please select your language by using the interpretation button at the bottom of your screen. The icon looks like a globe. Once you have selected your language from the drop-down menu, please select Mute Original Audio if you do not want to hear the English narration in the background. If you are on an Android or Apple mobile device, please click on the three dots in your meeting controls, then select Language Interpretation. Again, even if English is your preferred language, please do indicate this as the presentation will be given in French. The Humanitarian and Crisis Subcommittee is a very dynamic and engaging group. If you are at all interested in family planning in humanitarian and fragile settings, we would love for you to join us. No need to be an expert, just have some interest. Also, the hashtag for our session is hashtag ICFPHCS. If you are sharing ideas from this session on social media, please do use this hashtag as it will remain with us through the ICFP conference. During the panel, please don't hesitate to put any questions that you might have in the question and answer box throughout the presentation. You can find that at the bottom of your screen. Now I'm excited to move on to the presentation. I'm thrilled to be able to introduce today's moderator, who is not only an engaging presenter, but also a very skilled advocate for family planning in fragile settings. Jessica Kakesa is a medical doctor specializing in sexual and reproductive health and rights. She is originally from Goma, a city in the Eastern Democratic Republic of the Congo. She has worked in SRHR in conflict settings for over 10 years and has led and provided technical support to comprehensive family planning and post-abortion care programs across many contexts. She is an experienced SRHR clinical trainer and has led coaching programs to improve the quality of SRHR services, including family planning. She is a committed advocate for sexual and reproductive health and rights and is particularly passionate about expanding adolescents' access to quality and compassionate family planning services. Jessica currently works for IRC as a reproductive health technical advisor and provides technical support to country programs in the Great Lakes and East Africa regions. Thank you so much for sharing your knowledge with us today and for moderating this panel, Jessica.
Thank you, Megan. Thank you all for making time to participate in this session, despite your busy schedules. Thank you also to the panelists who have accepted to join us and share their experiences. Family planning is one of the most life-saving and empowering intervention in health. Despite an overwhelming need, family planning remains one of the biggest gaps in humanitarian response. Whether women are fleeing from a crisis or supporting recovery of their communities, they have shown that they want family planning. And these gaps can be closed if we commit to do the right actions now. Family planning must be recognized as a right of all women and girls, regardless of where they live or their displaced status. Regardless of context, donors and agencies should seize opportunities to provide family planning throughout a woman's life cycle and for vulnerable populations. This includes testing new promising service delivery models and scaling up high-impact intervention. Family planning, including long-term and permanent method, must be a priority in responding to acute emergency. Humanitarian interventions must incorporate comprehensive family planning at the beginning of every health response. This can be significantly improved by codifying family planning as a primary component of the international standards for reproductive health in humanitarian response. Donors must address the lack of funding for comprehensive family planning in crisis settings. All healthcare intervention should include family planning, whether donors and aid organizations are supporting crisis or recovery. Primary care intervention should incorporate family planning. Family planning should be available to all women and girls, regardless of where they fall along the relief to development continuum. But why preparedness? Despite the widespread recognition of the life-saving nature of SRH services in emergency, women and girls and other marginalized groups living in humanitarian settings continue to face severe SRH-related risk. The IWAC 2012-2014 global evaluation identified gaps in care stemming from attitude related to SRH, weak data, inadequate funding, poor commodity management and security, and compromised health system. Additional gaps included weak implementation of the MISP at the onset of emergencies, insufficient services for marginalized groups, and limited access to emergency contraception, long-acting and permanent method, GBV prevention measures, and clinical care for survivors, and safe abortion care. A more rigorous and comprehensive approach to SRH preparedness can help those gaps by integrating SRH into emergency risk management and capacity strengthening efforts. This will require better collaboration and coordination between SRH and disaster and risk management stakeholders, with SRH actors becoming familiar and engaging with existing risk management efforts and systems. Recent international frameworks emphasize the importance of preparedness to safeguard health and system, as well as improve care during emergencies. Emergencies, whether from natural hazard or conflict, threaten the capacity of government to respond and recover. They can cause long-term damage to health system, even those that may have been operating at a relatively high capacity. Precious development gains can be lost, and the effect of poverty and inequality intensified. The failure to prepare and respond to emergencies threaten to undermine hard-won progress on the 2013 Agenda for Sustainable Development and limits the possibility of achieving universal health care. Preparedness is thus a key of the humanitarian development peace nexus. This session is meant to bring together humanitarian and development stakeholders to discuss the challenge and opportunities faced in providing good quality contraceptive services to all affected people, all the people who are affected by humanitarian crisis across the humanitarian development continuum, from emergency preparedness to response and recovery. And this session will include short presentation of case studies of effective contraceptive services delivery in a range of settings, and then will come a session of question and answer. So I'm very, very pleased to announce that we have here three great presenters. So we'll be hearing from Julius Senabulia, who will discuss on family planning emergency response in Vanuatu. Then we will hear from Dr. Cyprien Masaka, who will be presenting on preparedness in the context of Ebola, that led to learning and improved preparedness and response to COVID-19. And then we'll hear from Dr. Amer Bashir, who will discuss the importance of preparedness and resilience in delivering FP services in Yemen. Thank you. So now I will invite the first presenter, who is Julius Senabulia from Vanuatu. And Julius is the program manager at Vanuatu Family Health Association, a member association of International Planned Parenthood Federation, IPPF. And he works there as a program manager. He executes both managerial and programmatic tasks and has successfully managed SRH emergency responses at national and provincial level in Vanuatu. He has previously held several coordination roles related to advocating for sexual reproductive health and rights in both stable and humanitarian contexts. In Vanuatu, he working together with key humanitarian stakeholders, partner. He has helped to increase the focus on meeting the family planning and other sexual health needs of population affected by disaster, as well as the host communities. And Julius earned a degree in social work and social administration from Kumi University in Uganda, and he graduated in 2005. So thank you and welcome, Julius. Thank you.
Thank you, Dr. Kakesa. I'm going to present on providing contraception as a part of humanitarian response in Vanuatu. My name is Julius. Allow me to share a snapshot of why Vanuatu is vulnerable to humanitarian crisis. Firstly, Vanuatu lies on top of the Pacific Ring of Fire with 9 active volcanoes. Except for unpredictable outbreaks such as COVID-19 pandemic, of course, and others. Otherwise, the annual earthquake and cyclone seasons are widely known by every person in Vanuatu, at least the adults. So Vanuatu has also been ranked the most disaster-prone country in the annual World Risk Index in 2020, which is a little bit saddening. So Vanuatu Family Health, anyway, has an active humanitarian response program funded by the DFID Sprint Initiative. On the 6th April 2020, as Vanuatu was under a state of emergency due to the COVID-19 pandemic, Category 5 tropical cyclone TC, Harold made a fall. To Vanuatu, it was a double tragedy. Reason being, it intensified challenges that Vanuatu has always faced, trying to reduce the 24% rate of unmet need for family planning, and also the 81 out of 1,000 adolescent fertility rate that is currently faced in the country. The TC Harold caused severe damage to 127 health facilities across the 3 provinces where disaster hit, and disrupted services, especially for the 159,474 people who could not access. That is almost 52% of the population. So more so, COVID largely caused difficulties in procuring and transporting commodities and supplies, especially family planning and others, and also caused the limited movement of the humanitarian response team. Talking about how Vanuatu is prepared always especially coordination. Vanuatu Family Health Association has a focal person in place, who is also supported by 3 technical nurses. And these people help in preparation of family planning, SRH supplies, setting up response teams, medical stations, and also setting up mobile clinics. So we were able to, through that team, to put together a medical team recruited from a pool of trained nurses, trained people who were trained in the minimum initial service package for SRH. And they came from Vanuatu Family Health, VFHA, the Ministry of Health, or MOH, and the Vanuatu Society for People with Disability staff. So they included altogether 6 midwives, 3 nurse practitioners, 5 registered nurses, 1 dentist, 7 public health officers, joined by peer educators and volunteers. The response team received pre-deployment orientation sessions on all the cases that were to be working on, especially COVID-19, family planning, contraception, SGBV, and other issues, SRH issues. And these were facilitated by a team from Ministry of Health, UNFPA, Vanuatu Family Health, and Vanuatu Women's Center. Vanuatu is privileged to be active member of the National Health and Protection Clusters that worked under the supervision of the NDMO, the National Disaster Management Office, and were represented in these coordination meetings by the humanitarian focal person and the program manager. So we were present in all these meetings, and our presence there was basically to obtain information regarding damage assessment and also participate in planning, joint deployment, and so of course sharing resources, because we understand that we cannot do much without other support. So on the issue of delivering of family planning services, Vanuatu Family Health set up 2 temporary medical stations and 104 mobile clinics to provide family planning, contraceptives, and other SRH services. So we were there to save lives. Our response team reached out to 106 villages and prevented 722 unplanned pregnancies. And out of these, 153 women received LARCs, or long-acting contraceptive methods, especially Gérer. And we supplied 6 cycles of pills to clients to help reduce the need for them to frequent or to visit the health centers. In regards to prepositioning of family planning and SRH commodities, we had adequate supplies to meet all the demand. Our limited starter stock was supplemented with the emergency supplies from the Ministry of Health, especially the Central Medical Store, UNFPA, and Family Planning New South Wales. So we also provided community education sessions combined with COVID awareness on family planning and SRH. Our response team set up hand washing stations at all medical stations and outreach clinics, and assisted demonstrate proper hand washing techniques to the villagers. We had some lessons learned in this response, mainly providing family planning as a part of emergency response. We take it as an essential activity. Reason being that most health centers were severely damaged, and that meant users of these services or facilities needed alternative access to family planning, and which we did. And also all local nurses who operated the damaged and those centers that were still standing were also victims of Cyclone Harold. So they needed some time off to organize their homes and recover from stress. So our response team were there to bridge that gap. Some women in remote villages were able to access family planning services for the first time. So to them and even to us, it was kind of a blessing in disguise. It's a lesson for us. The last lesson for us was about the response team working with public health staff in each of these settings that we visited, especially building capacity on family planning service provision through mentoring. We did some kind of mentoring and training on inserting Gérer or inserting implant. This is a snapshot of photos that we took in the field to illustrate what our nurses were doing. So these nurses you see here were inserting Gérer. And of course, we integrated hand washing as a precaution for COVID prevention in our activities. Thank you so much.
Thank you very much, Julius, for this wonderful presentation. We are very looking forward to the discussion we'll be having. People, remember, you can submit already your question. We are going to have a Q&A session at the end. But for now, let's move to the next presenter, who is Dr. Cyprien. Dr. Cyprien Masaka Lopepo is currently the International Rescue Committee's Deputy Health Coordinator for Sexual and Reproductive Health in DRC. He has been a doctor since 2005 and has a master's degree in public health and has over 8 years of experience in clinical service provision, emergency, health program management, and health system strengthening in the DRC. And Cyprien is also a skilled clinical trainer, program manager, and evaluator of represents IRC DRC in a variety of health and nutrition fora. He is also experienced in implementing SRH in various epidemics contexts, including Ebola, cholera, and COVID-19. Thank you and welcome, Dr. Cyprien.
Thanks, Dr. Jessica. Hello, everyone. I will speak in French for well understanding.
I'm working at EFC, and I am going to talk to you today of a case study that we did in Democratic Republic of Congo for family planning, which could implement the lessons learned from the Ebola epidemic. These lessons were applied to continue applying family planning services during COVID. As you know, the RDC is a country which is prone to several crises, and these crises are linked to the lack of security and armed conflicts that are usually in the eastern part of the country, but also it's a country that's facing several epidemics, the last one being the Ebola one, which manifested itself for the 11th time in the country, in Ecuador. But before Ecuador, the 10th epidemic manifested itself in the eastern part of the country. And now there is a very fragile health system. And when it comes to family planning and the contraceptive preparation, it's very weak. And if you see the studies since 2018, this prevalence is around 28%, whereas using the service is below 25% for the whole of the country. As I said, we had the experience of Ebola twice since 2018, the 10th manifestation being the longest one, and it started in August 2018, and then it gave way to the 11th one in June 2020 in the eastern part of the country, and we saw more than 3,000 cases in 2018, whereas for the 11th, we have 130 cases with 55 deaths. So the mortality rate is beyond 50% for both epidemics, and therefore these epidemics found health programs, mainly FP programs. What did we do? Mainly to coordinate the reaction to the epidemics, the COVID epidemics, with the FP services and sexual and reproductive health in general. Of course, we were able to continue with whatever we already had in place that we used during the Ebola epidemics, mainly triage stations in front of each structure. We have a screening, we check the temperature. We were able to implement measures at the entrance to every room. For example, we had hand washing stations, and mainly by organizing consultations with the clinicians and even hospitality admissions. And we trained the service providers in order to be able to bring the supplies in an adequate way. Since COVID, a lot of actors are moving for a long time. We were able to secure supplies for a 6 month period. And if we don't have movements, at least it's going to be, the supplies will be available for the health centers. We did some field visits. We avoided field visits remotely through social media, telephones, just to collect data. And within the FP programs, we were trying to do follow-up exactly to see the adverse effects and what are the effects of our interventions at the health center level, but also as an entry door to mobilize people and to have presentations on health. And we were organized counseling and training sessions with small groups with a maximum of 5 people, for example. And of course, all these measures were adapted to what we did during the COVID pandemic. And we were able again to continue the family planning program. And also we were able to provide contraceptives. We gave a plaquette for each month, and now we give 3 months supplies in order to avoid contacts. We wanted to orient our clients who go from counseling often, and we went to a bigger waiting period between the contacts. That's why we were giving supplies for 3 months instead of 1 month. Now, we also worked with adolescents, young women, and we put together social media and sensibilization through various means. Also, as you can see on the screen, the epidemics have a real negative impact on the programs, and we experienced that during Ebola. This experience allowed us to try to absorb the shock of COVID-19 through our various services, and you will see it in our various outcomes. Number of clients who studied contraceptive methods. We have a family planning project in the country, and this since the 2006, but in the period 2018-2020, we had the Ebola in August 2018, as you can see, first red arrow. Before that, you saw that family planning programs were in a steady progression. And with the epidemic of August 2018, before the month of September, where generally each year we have a peak, because that's when we organize campaigns during the National Days of Contraception. But given that the epidemic started 1 month before the start of our campaign, everything had been prepared already. There was a good mobilization. So we did have a peak, but the epidemics dealt a fatal blow to our campaign, since we didn't put together all the measures to guarantee the health of our clients. And as you can see, you have a real low for about 4 or 5 months. And we couldn't deliver all the mitigation measures. And once we put together on the field these measures, like in January and February, we started to increase progressively the use of our services, to the point that in March 2020, when the epidemics reached DRC, especially in the eastern part of the country where we have these programs, you can see that COVID did not have an impact, because contrary to August 2018, we were able to maintain the growth in the use of our services, even after the tense epidemics. But our adaptation measures to Ebola and mitigation measures to Ebola were strengthened and used. And now it allowed us until today to deliver family planning services without being strongly impacted by COVID-19. And therefore, one of the lessons learned is, I believe, that the DRC had to face one epidemic already, and the measures that were taken allowed it to resist or absorb the shock of COVID-19. As I mentioned earlier, COVID-19 did not impact too much the family planning services, because all these measures were used with following Ebola. And therefore, DRC is ready to face other epidemics, even if it's not COVID, especially by using these measures put in place. Thank you, and we are available to answer any questions about our presentation. Thank you.
Merci beaucoup, Dr. Cyprien. Thank you very much. Thank you for this great presentation, very informative presentation, where we could see how the team learned from the Ebola outbreak, and they were better prepared when COVID-19 struck. And we could see on the result that the team was able to maintain access to family planning services during that crisis, which is still going on. Thank you. Let us move to the third presenter, who is Dr. Amer Bashir. So Dr. Mohamed Amer Bashir has more than 13 years of international development experience focused on health and nutrition programming. His expertise includes maternal, newborn, and child health, nutrition. His experience is complemented by his focused knowledge not only in health and nutrition, but also in the child rights-based programming approaches of child participation, inclusion, diversity, and non-discrimination. Amer brings significant experience from his work with international non-governmental organizations such as Save the Children International, as well as a strong contextual understanding of Pakistan, East and Southern Africa, and Middle East. Dr. Mohamed, welcome.
Thank you so much. Thank you for the opportunity to talk about Save the Children's program in Yemen. In this presentation, I'm going to go over some aspects of our family planning project and how we've been able to steadily progress in some very challenging circumstances. Let me just quickly touch on the situation in Yemen at the moment and quote some figures for you. So at the moment, according to the humanitarian response plan for Yemen, we're looking at around 17.9 people who are in need of health assistance, and 9.7 million of them are in acute need of health services. 63% of pregnant and lactating women and girls suffer from anemia. 1 in 60 women face a lifetime risk of maternal death. All deaths that are recorded among children under 5, of all the deaths among children under 5, 46% occur during the neonatal period. Unmet needs for family planning, they exceed 50%. Only 25% of pregnant women complete a minimum of 4 antenatal care visits. Skilled attendance applies to only 45% of all births. And postnatal care needs for mothers and babies are only met at 20% and 11% respectively. Similarly, looking at immunization coverage for DPT-3 and measles, they stand at 71% and 70% respectively. And just 8% of children under 5 benefit from vitamin A supplementation. So I'm just quoting these figures just to set the scene of for Yemen, the context in Yemen and the context that we are working in at the moment. Save the Children has been operating in Yemen since 1963, and we currently have a nationwide presence. Reproductive health services have always been an integral part of Save the Children's programming approach. And in Yemen, our specific focus on improving family planning services in humanitarian settings started in 2013. The overarching objective of that project was to create demand for services, capacitate service providers to provide quality care, ensure availability of commodities, and improve the data systems for decision making. And all our work has been through the public health system, and we're working with the local service providers and communities. So this model that I just described, where we are looking at training and mentoring frontline health providers, providing commodities and supplies and support for commodities, and mobilizing support for communities and mobilizing them, and use of data for action, all contributing to quality health services, that remained consistent after the conflict in 2015 as well. And I'm briefly going to go over each of these components and give you a little more detail on what we did within these particular components and what we achieved. So on training and mentoring of staff of frontline health workers, one of the advantages of having initiated the family planning project before the conflict hit was that we already had trained staff available in the areas that we were working in, and some of those areas were worst hit by the conflict, places like Hodeidah Governorate, for example. And since these staff were already functional at government health facilities, they were able to continue to provide services with support from Save the Children through on-the-job trainings for midwives, nurses, and doctors. And another aspect which contributed towards supporting the government was like, government management staff on routine supportive supervision, was that we also tied in our use of data for decision making and brought in the government in the data collection processes, analyzing of that data, and also doing supportive supervision visits along with the government staff to the supported health facilities that we were working at. One of the other factors which helped for continued services post-conflict was that we were able to procure commodities when we initiated the program. And we'd already established our supply chain, and commodities and supplies were in country. And we were able to use these pre-positioned stocks for continued service delivery at the facilities that we were supporting. Save the Children also diversified the method mix and introduced implants into the method mix in Yemen. And we collaborated closely with UNFPA and other UN agencies and other partners on ongoing RH work in Yemen. We still do that at the moment as well. And we continue to work with local staff at health facilities on supply chain and improving stock management, making sure that they have the capacity to track stock utilization, making sure that they have the ability to predict consumption, and ensuring that we don't have stock outs at supported health facilities. Our community mobilization efforts have continued post-conflict and with slight contextual adaptations. So what we've done is that we've formed smaller groups at village level, and we've also formed targeted age groups based on service uptake data that we were receiving from health facilities to focus more on specific age groups. And these mobilization activities were done through community volunteers who were local to their areas, and they promoted an integrated package of services which was being offered at the health facilities that we supported, which was based on the essential services package for Yemen. And given the context in Yemen, in order to increase the uptake of services, these community volunteers were also they also involved husbands and other influencers and decision makers in their community engagement activities. And as you will see in subsequent slides, when I show some of the progress on about the project, that uptake of services has remained pretty consistent even during COVID times, with a slight dip when COVID hit Yemen. But there was a subsequent increase after that as well. And the formation of these smaller groups at the community level, we were able to continue community mobilization activities post-COVID as well with COVID adaptations for community outreach programs. On the use of data, I briefly mentioned this earlier. So we trained health facility staff, Save the Children staff, along with Ministry of Health staff on data collection, the use of data for program decision making. And this was done in several ways. We introduced a DHIS2 database that is still functioning and that's still running. We introduced data review meetings with health facility staff, Save the Children and government staff, register reviews, making sure that data was consistently collected and data quality was up to par, and client exit interviews for measuring client satisfaction and ensuring quality of services. So this graph shows a steady increase in uptake of services, and we've got a breakdown by type of commodities utilized and type of services offered. So if you look since 2013, there has been a steady uptake in services, and it's consistent across the type of services and the type of commodities provided. So in 2015, essentially there would have been a dip in services, but we see that there is consistent increase even post-conflict going into 2016, 17, and beyond. This is talking about the percentage of LARC users. So we see that in 2013, we see a slight increase going towards 2014. And 2015, there is a dip because of the upsurge in violence in Yemen because of the conflict. But after that initial slight dip in 2015, we see like, again, uptake of services going up for LARC in 2016, and it's remained consistent at around 30% through 2020 as well. So again, this speaks to the community mobilization component, the availability of commodities, the fact that trained service providers were already there, and we were able to continue services at health facilities during the conflict and post-conflict. I mean, to the current time as well. This is on the number of family planning clients for 2020. We see here so the first case of COVID-19 was identified in Yemen in April. So we see a dip in service uptake in May of 2020. That was because of uncertainty around the COVID-19 itself, people's perceptions around COVID-19, safety of services provision at health facilities, the facility staff, service providers themselves, having concerns around COVID-19. But again, the fact that we continue to work in smaller groups at the community level, and we introduced COVID-19 adaptations for health service delivery in line with guidance from the health and nutrition clusters. We see a steady increase going into June, and obviously, the service provision is steady August, September, and December 2020. Thank you so much. So back to you guys. Thank you.
Thank you very much, Dr. Amar, for this powerful presentation. We've seen how preparedness has resulted in impressive resilience. Thank you, Dr. Amar, for have pointed out the different key building blocks to achieve quality of services. He mentioned capacity building, system strengthening. He mentioned availability of commodities and supplies, which is most of the time is also a big gap. He mentioned using data for action, but also community mobilization, how they supported community to make sure that they mobilize for utilization of services. And like I said, we could see looking at a result and impressive consistent uptake despite the situation. Thank you very much. So this was what we wanted to present, and now we have half an hour for question and answer and discussion. So the floor is open, and you can submit your question, and we will be responding. We have our three presenters, and I'm looking forward to this great discussion. So I just want to announce that Marilyn Nyaboga, who is based in Nairobi and works for with IPPF as a senior SRH advisor with the global humanitarian team, will be answering questions addressed to Julius' presentation. So we'll have Marilyn, Cyprien, and Dr. Amer responding to questions. We already have a couple of them. So the first question is addressed to all the three presenters. So I will go ahead and read the question. If a family planning commodity is not registered in the country, is it possible to obtain waivers to provide them during emergency response? In other words, if the product is not registered in the country, can we supply it in an emergency? So this is addressed to the three of you. Anyone?
Hi, Jessica. This is Marilyn. Thank you for the question. I will start responding to it. So I don't think we've had such a challenge in Vanuatu. we work very closely with the Ministry of Health at national level and at provincial level. So we have all these discussions, and everybody's aware on what type of family planning products are needed in the country. So we haven't had this challenge, but in case, for example, a new method is coming into the country, discussions are there, all the partners are invited, UNFP is there, discussions are made, and there's a possibility to import that drug. Yeah. So it's not a challenge. I think coordination is important, and consultations with the Ministry of Health and all the other partners on the ground.
Thank you very much, Marilyn. Dr. Cyprien, you have something to add on this, or Dr. Amer?
Yes, Dr. Jessica, of course, in the DRC, most of the products are used on a local level. We have DKT, which is the main delivery channel. We do not have any worries because of waivers of products during the COVID pandemic, because we had the system in place.
Merci beaucoup. Dr. Amar?
Yes, hi. So this is a peculiar situation. So if I haven't come across it to be honest, but if if this were a situation, one of the possibilities would be to channel this request through the relevant cluster, through the health cluster or the RH SERP group, and get assistance from other partners and UN agencies from within the cluster, and try to negotiate that early access or early approval with the relevant ministry and get those products in. So that could be one of the solutions that I see within a humanitarian setting. That could be a possibility. Thank you.
Thank you. Thank you. Thank you very much for responding to this question. Let's move to the next one. Yes, thinking about providing FP services in the context of COVID-19, what systems have been put in place to keep providers safe, and what have you found to be the burden of COVID-19 among health workers? Again, this one is to any of the three presenters.
Okay, let me start answering that question. This is Marilyn Nyaboga again from IPPF. So we've put a lot of measures to keep both the staff and the community safe from COVID-19. So first, initially, when the outbreak started, IPPF senior staff members, developed protocols that were shared globally with all our member associations, and also training was done so that everybody was aware, like, what are the minimum standards in all the facilities. So we had minimum standards, like everybody had to put on a mask. We had to have hand washing stations. They had to check temperatures in all the facilities. So all these challenges, all these activities were put in place by most of the member associations. But of course, some of the associations had challenges, especially some countries, for example, in the Pacific, had limited access to PPE during the initial stages of COVID-19. Due to the government lockdown, they were not able to import these products from the nearest countries. So they had challenges, and the minimum stock that was there was used for high-risk areas where there was a lot of traffic and people were moving up and down. But we put all measures to ensure that we're able to protect all our staff and community members at large. Thank you.
Thank you very much, Marilyn. Okay, Dr. Amer, you wanted to say something?
Yeah, I just wanted to add to what Marilyn said. I mean, just picking up on that. So for Save the Children, the COVID-19 was a unique experience for all of us. But given the global presence that we have as an organization, and as things were developing across the globe regarding COVID-19, there was a lot of learning coming in from other countries as well into Yemen, for example. We already coordinated efforts to put together program adaptation guidelines for continuity of services at health facilities, and we were cross-learning from different country offices as well. So that was a really, really important experience on COVID-19. So for Yemen, we set up program adaptations to make sure that services were continued, providing PPEs to service providers, setting up triage facilities at facilities where we were working. Most of our facilities are primary healthcare facilities. Even then, taking the necessary measures, making sure that health staff and communities remain safe, whether it's whether it's service provision through static facilities or mobile services through outreach, community work. Yeah, those primary concerns were taken into consideration, and we did learn from other country offices as well on that.
Thank you very much, Dr. Amer. I have another question for Dr. Cyprien. So it's related to what you mentioned on the use of media, such as Facebook. People would like to know if you could expand on that a little bit more, and maybe explain if that was effective, and also if we provided, how you made it possible. Did you provide data to the health workers since they were using their phones?
Thank you so very much. This was one of the adjustments which we were able to do when we did the assessment of our system. With COVID, people couldn't move around. There were movement restrictions, and there was a large need. But as I told you before, we had the experience of Ebola in our bones, and so we knew how to work with prevention. And when COVID hit, then we used everything we learned from Ebola. We talked with the different district structures and also with the community members. Especially we talked to the adolescents who were trained with regards to the different structures. And so when we made these adjustments, we incorporated the media. So we added the use of telephones. And the benefit here for the regions where we worked are regions which are relatively open. Therefore, it was possible for us to connect the phones. It was important for the calls, but it was even more important for internet connection. We were able to exchange data and also to talk with adolescents on Facebook. We have a free Facebook, and this was then easier for us. Adolescents were able to converse, to communicate with the doctors, with the nurses. This is something we put in place. It was important for us to maintain this type of communication, even if the adolescents were not able to move around. And this is how we put in place the phone system. Thank you.
Thank you very much, Dr. Cyprien. The next question is for Marilyn. So Julius talked about providing LARC, especially implants, Jadel. Can you please share with us the Vanuatu experience in providing IUDs during crisis, and particularly the postpartum IUD?
Yes, thank you, Jessica, for that question. Sorry, my mic was off. So for Vanuatu, we are providing all family planning methods, both short and long term, but IUDs are not very common. Many women prefer to use the implants. but we are trying, making all efforts and doing a lot of community awareness and also engaging the Ministry of Health and also, the community at large to educate them about this method because it's important for us to introduce this method, especially in humanitarian setting. So when you go to our regular clinics, this method is there, but in a humanitarian crisis, I think the teams find it a little bit difficult to use it because it requires a lot of infection prevention. And most of our teams are providing services through mobile clinics. So I think that's a challenge to them, but I think there is a way we can go around it and provide these services to the community. Thank you.
Thank you very much. If others have something to add on IUD in the use of IUD in emergency response. Well, maybe we'll move to the next question. And the next question is to Dr. Amer. How did you conduct the data review meetings, and were these done remotely or in person? And if remotely, how was the participation, and were there any issues with internet services?
Thank you. So usually the register reviews and data reviews are done through the supportive supervision process, where we have Save the Children trained staff who work very closely with their particular health facilities that they're responsible for. And they're usually done at the point of service delivery with the data registers there. Recently with COVID-19, some meetings have to be done remotely, and it's true that can be an issue with internet connectivity. But in the field, the personal visit by staff to the health facility for data reviews, that usually works best. Yeah.
Sorry. Thank you very much for your response. So the next question is for the three of you. So all these family planning services which were presented today, were they coordinated alongside with maternal and neonatal health services? And if yes, how?
So for Save the Children, the way that our health and nutrition programs are set up, we provide a comprehensive package of primary healthcare services through our programs, and that includes maternal, newborn, and child health, skilled delivery, antenatal care, postnatal care, vaccination services for children. So it's a really good opportunity for us to integrate the services, FP services within the other components of the programs as well. So making sure that there's linkages between the FP counseling components and and the ICF counseling components, cross referrals between the two programs. So it really helps when you are supporting a health facility holistically and looking at an overall package of services. And it's easier to integrate FP into the broader spectrum of services that are being provided.
Yeah.
Thank you.
Thank you very much.
Vanuatu?
Yes, Marilyn, go ahead.
Yeah, so for Vanuatu, we're providing comprehensive SRH services in general, and specifically we're providing most of the MISP services. So GBV services were available, and maternal and referral health services, apart from family planning services. So women were able to access a variety of services. And Vanuatu setup is different. After the cyclone hit the country, people did not move to camps, but kind of they are based in remote locations. So it was difficult to access those locations. Our staff had to use boats, big vehicles to be able to access those remote locations. But we were able to still provide the service. We were lucky enough that COVID-19, we had very few cases of COVID-19. So we were still able to move around and support and supervise the staff based in the different areas. And then also we worked very closely with the provincial health administration and the health workers who are based in the remote health facilities. So they were able to mobilize and we were able to coordinate services throughout the response. Thank you.
Thank you, Marilyn. Dr. Cyprien?
Well, I believe that for FP, it's often integrated to the area of services for infant and mother services. Even us, we have programs where beyond primary healthcare, we also have protection services for the women. It's basically an integrated package. Besides, when we don't have the other programs, you already have Ministry of Health and other partners who took in charge other facets of the mother's health. In general, the programs are integrated, and we support in an integrated fashion by taking into consideration all the interaction between the other services of mother's health and the facet of family planning.
Thank you very much, Dr. Cyprien. The next question is on the messages. So maybe I will address that to Dr. Amer. How were the messages in the community disseminated and which age groups did you target?
Thank you. So the community level message dissemination, like I mentioned, is done through community health and nutrition volunteers who are trained on messaging at their community level, forming the groups that in their own communities on a smaller scale. So small groups, not like no extensive groups, and they obviously receive training from Save the Children on standard IEC materials that they do reference and use in their community mobilization sessions. So that's how it's done at the community level, and that's why I mentioned during COVID-19, since it was a smaller group, and we did put in place COVID-19 precautions and adaptations. We were able to continue the community work that we were doing.
Thank you very much. When in the Julius presentation, he mentioned that emergency response introduced many clients to contraception for the first time. So did DRC or Yemen have a similar experience?
I mean, I'd have to go back to the data and sort of look at the comparison of new acceptors and continuing acceptors. But yeah, I assume the situation would be the same, that we would have an increase in the number of new acceptors, given that we were able to reach communities with information and good counseling being provided. So yeah, but I'm not going to make any assumptions right now. I'd have to go back to the data. And if they're happy to leave their emails, I'm happy to get back to them with more information, more specific information.
Thank you.
I can just
Thank
add,
you, Dr.
Maybe?
Yes.
Sorry, Jessica, I can add to what Dr. Amer said. We saw this trend when there were acute emergencies happening within what was happening inside Yemen anyway. So when new front lines broke out for conflict, we were able to kind of provide outreach to facilities that were not originally on our list for the program. So as we went to new facilities, we clearly had people moving, IDPs coming from far off areas and accessing services for the first time. So yes, we would have to go back and look at the data, Amers, to be very, very sure, but this was a trend that we observed very often with new acute emergencies within the ongoing chronic state of emergency.
Thank you very much. And this is for the three of you. So it's related to supply chain. due to COVID-19 and generally in emergency, we know supply chain is a challenge. So could you please talk about how you have addressed the supply chain challenges in your setting? You have mentioned a couple of them in terms of pre-positioning contraceptive, but yeah, if you can speak more about that.
Yeah, thank you, Jessica. For Vanuatu case, in terms of supply chain, we have a very strong coordination with the Ministry of Health and other partners on the ground. So immediately the crisis happened, we had meetings with the National Ministry of Health, and they were able to give from the central medical store, they were able to provide our member association with a variety of medical supplies for them to be able to respond to the emergency. Also, we got some supplies from UNFPA and other donors and volunteers. So I think partnership and coordination is very crucial before the emergency as you're preparing and also immediately after the emergency. Thank you.
Thank you very much, Marilyn. Dr. Amer and Cyprien, would you like to add something? Yes.
Yeah, sure. Just wanted to add, when I mentioned that we started off the project, the NFP project in 2013, and that gave us around a 2-year sort of window where we're before 2015 when the conflict actually scaled up. So it was rather more convenient to bring supplies in, and luckily we did have supplies in country through the project. But definitely there are challenges when in conflict situations to get supplies in, and logistics is always an issue that at the program level we have to be conscious of and we have to keep tackling. And like the honorable person from before me, Marilyn, just mentioned, it boils down to how well coordinated your efforts are within the clusters and subclusters, how well informed you are and how well coordinated you are with the local ministries, where there are opportunities where other partners might have supplies that they can lend to you for a short period of time. So just to cover any kind of urgent gaps that might be there while you're waiting for your supplies to come in, and then obviously share those supplies when they're in country with the other partners as well.
Thank you very much. Cyprien, you would like to add something on the supply chain challenges?
Yes, of course. It's the same as a Yemen situation. Most supplies, especially contraceptives, are delivered at the local level. But at the beginning of the crisis, even the countries who are restrictive movement, we were lucky that the projects were already established before, and we have a high level of supplies in our warehouses. So we were able to supply the various installations for a longer period, because in general, to supply every 3 months, we could do it, and each installation was supposed to be supplied every month. So with this restriction in place, we had to give like a 6-month supply, because we had to take into consideration the need. And also other partners were giving like 3-month supply. So we were able to last in this manner. However, you had this coordination with other partners who also had installations on site. And if there's a structure that was almost out of supplies, we had to be organized in order to supply them and lend them the supplies. But even among structures, if one structure was not using all their supplies, they were able to supply each other. So we put together some kind of follow-up at each level of the quantities of supplies, even over the phone. This would allow us to orient the various supplies towards the various structures. That's for the DRC.
Merci. Thank you very much. So we only have 5 minutes remaining. So I'll just take one last question. And this is again to the three of you. So each of the presentation described well-rounded SRH responses that allowed for family planning services to quickly resume during the COVID pandemic. So based on your experience, what aspect of SRH preparedness needs to be strengthened before the next crisis hits? And what more could be done to better prepare to maintain family planning services?
Yeah, that's a very interesting one. So COVID-19 and FP services, how to be prepared. I think, like, just based on what I've seen is that uh, making sure that there is enough information shared with key service providers. Uh, they have sufficient personal protective equipment and training to use that protective equipment. Health facilities are safe. There are IPC materials available. Communities are aware of how to access services safely. And all this is done in line with the broader understanding with the local ministries, whether we're talking at the national, provincial, or district levels, and in confidence with the relevant clusters as well. So whenever COVID is like, there's going to be an upsurge in COVID, there will be partners that want to come together to make sure that there is continuity of service. So being part of those discussions and learning from each other, I think those are some of the key factors. But yeah, in terms of logistics, making sure that supplies are there, yes, that those components of preparedness and information sharing definitely contribute to safe service delivery in the COVID-19 context.
Thank you very much, Dr. Amar. Yes, Marilyn wanted to add something?
Yeah, just to add to what Amer said, I think COVID-19 was new to many locations. So, we were doing a lot of preparedness for SRH and family planning supplies, but we didn't prepare well for epidemics. So we didn't have those hand washing stations and, those PPEs. So initially, during the initial phase, I think most of those items were missing. And in Vanuatu, in some of those supplies had to be imported from, the neighboring countries. So I think that was a gap that in future, I think we need to fill it. The other thing that we need to be prepared is on family planning supplies. There's prepositioning and they're always available from the Ministry of Health, but they're not enough. As we are continuing to do community awareness, more women are coming up to request for family planning supplies. So I think we need to make them available, especially the long-term family planning methods. And also we need to improve on family planning method mix. Yes, thank you.
Thank you very much. Thank you very much to the three of you. Thank you to all the panelists for your valuable contribution, and also thank you to the audience for this active participation. I think we are at the end of the session, and I just wish you a good rest of your day for some and night for others. Thank you very much.
Thank you for listening, everyone. Thank you. It was a pleasure.
Bye. Thank you very much.